Hi, thank you to everyone who has worked to put together the second annual Computational Data Neuroscience Symposium, especially during these challenging times. Thanks to the Brigham and Women's Hospital, the Harvard Department of Neurosurgery, and the Harvard School of Public Health Onnela Lab who have sponsored the event. My name is Parastou Fatemi. I am a neurosurgery resident at Stanford, and I will be presenting on work that we have been conducting in Dr. John Ratliff's Spine Outcomes Lab related to using big data to build predictive models applicable to patients undergoing spine surgery. I have no disclosures, and Dr. Ratliff's disclosures are listed on the slide. I will discuss two main projects that we have worked on for the past few years and share lessons that we've learned using big data to build predictive models that are relevant to the clinical care of patients undergoing spine surgery. The references to the published studies are listed on this slide. The first project is related to opioid use in spine surgery. As many are aware, opioid abuse remains an epidemic in the US. Although rates have improved in the past few years, still in 2017, 1.7 million Americans abused prescription opioids, and 47,000 died from opioid overdose. As spine surgeons, we often see patients who have chronic low back and or lower extremity pain, and many of whom are on opioids preoperatively and are prescribed opioids after surgery. So we wanted to understand the patterns of opioid use in this patient population, and then to develop predictive models aimed at identifying risk of chronic opioid use following spine surgery. An insurance claims-based national database was the best option. So using the Truven Health Market Scan database, we extracted a retrospective longitudinal cohort of patients who were not initially on opioid prescriptions and then went on to be diagnosed with low back or lower extremity pain and later had spine surgery. The pattern of prescription opioid use were evaluated post-diagnosis as well as post-operatively for up to 1 year after surgery. In total, about 19,000 previously opioid-naive patients with newly diagnosed back or lower extremity pain underwent spine surgery within 1 year of diagnosis. Of these patients, about 5% met criteria for long-term or chronic opioid use post-operatively, while 95% did not. Amongst patients on opioid prescriptions, we observed two distinct groups demonstrated in this Kaplan-Meier curve. Patients with frequent prescription opioids, defined as 6 or more opioid script refills in 12 months, took longer to come off opioids, and by 1 year after surgery, were much more likely to remain on prescription opioids compared to patients in the low frequency group, demonstrated by the three curves in the bottom of the Kaplan-Meier graph. In fact, patients with the low frequency use of opioid prescriptions postoperatively were about 4 times as likely than the high frequency group to discontinue opioids by 12 months postoperatively, even after adjusting for variables such as age, sex, and type of surgery. Another finding was that the preoperative frequency of opioid prescription predicted long-term opioid use following surgery in a stepwise fashion. As you can see, the top curve in the Kaplan-Meier is broken down into 3 separate curves, as is the lower curve. Those 3 separate lines demonstrate the frequency of opioid use preoperatively. In fact, the strongest predictor of postoperative high-frequency opioid status is the use of preoperative opioid prescriptions. Here, each concentric circle represents one opioid prescription fill, with the innermost circle representing the first fill and the outermost circle representing the last fill within 30 days after surgery. In the 30 days following spine surgery, many long-term opioid users demonstrate unique opioid sequences that are not observed in the non-long-term opioid use cohort. For instance, the orange bar here represents long-acting opioid medication. And you can see that in the long-term opioid users, the long-acting opioid prescription is much more prevalent than in the non-long-term opioid users. Here, panel A shows the mean daily opioid dose amongst long-term patients remains high, while the non-long-term opioid users have a steady decrease in daily opioid dosage starting at around post-operative day 5. These panels demonstrate that a heat map of daily opioid dose for 100 randomly selected long-term opioid users, as well as 100 randomly selected non-long-term opioid users. And these also show a clear difference at about post-operative day 6 to 10. So with these findings in mind, we then went on to use demographic, medical, psychiatric, preoperative opioid use, and 30-day postoperative opioid use variables to generate 7 predictive models of long-term opioid use. We randomized an 80-20 split of the cohort using the 80% as a training set and 20% as a testing set. Various accuracy metrics were used to evaluate the models. Across all the models, the full logistic regression model had the best combination of AUC and sensitivity. And because we wanted to have our model serve as a screening tool, it was important for us to not only maximize AUC, but have a really good sensitivity for the model. The takeaways of the study is that we were able to develop a predictive model to screen for increased likelihood of long-term opioid use following spine surgery in patients with recent diagnosis of low back or lower extremity pain who were not on prescription opioids pre-diagnosis. We hope that this will improve identification of patients at high risk of prolonged opioid use and enable early intervention and counseling. And this model is available on the website listed here in the slide. The second project that I wanted to talk to you guys about is related to complications after spine surgery. So postoperative complication rates associated with spine surgery vary widely by patient, diagnosis, and procedure-related factors. And a validated tool for predicting medical and surgical complications following spine surgery is lacking. So we aim to develop and evaluate a set of predictive models for common adverse events after spine surgery using big data, and then to externally validate this model with a prospective cohort of patients at a single academic institution. We use a combined cohort of 1 million patients from the MarketScan and CMS Medicare databases. Using this, we developed 3 predictive models that were generated using patient demographics, location of spine procedure, comorbidities, type of surgery, as well as preoperative diagnosis. A randomized 70-30 split was utilized. The logistic regression model showed the highest AUC, and the calibration plot for this model demonstrating the prediction versus the actual probability of adverse events was in good agreement with an intercept of 0 and a slope of 1. Interestingly, Medicaid status was one of the most important factors in predicting the occurrence of adverse events. In fact, Medicaid recipients had increased odds of complications by 20 to 60% compared to non-Medicaid patients. After developing the model using big data, we then externally validated the model using a prospective cohort of all adult patients undergoing spine surgery by faculty in the Department of Neurosurgery at Stanford Healthcare between April to October of 2018. No exclusion criteria was applied. And we further defined the risk categorization as low, medium, and high. This was done using initially the large cohort and dividing that cohort into 3. When we divided the patients into thirds, we noticed that the low-risk patients had 17%, the low-risk group had 17% or less risk of postoperative complications, the medium risk 17 to 28%, and the high risk greater than 28%. So then this categorization was applied to the predicted probability of developing complications divided by these risk categorizations in the prospective cohort. And this is demonstrated in this graph. So there we saw that the observed versus predicted incidence of postoperative complications on this prospective cohort, as stratified by risk categorization, was in good agreement, as demonstrated here. The takeaways from this study is that we demonstrate an external validation of a big data-derived model predicting adverse events following spine surgery. This is a powerful tool as it has no limitation regarding specific procedures, indications, or patient socioeconomic factors. And results are presented as absolute percent risks and further categorized into low, medium, and high risks. Our hope is that this work will be helpful in shared decision-making with patients preoperatively and in developing management pathways in spine surgery. And this model will also be made available online. So what have we learned over the past few years using big data in developing predictive models in spine patients? Well, what we can share with you is that a significant amount of prep needs to go into developing the cohort and the study design. This is perhaps the most important part of doing, in our opinion, predictive modeling in spine research. You have to keep in mind that each data set has shortcomings, and this needs to be discussed and considered when designing the study. Close collaboration with statisticians is key, especially for clinicians who are interested in doing this research who may not have the nuanced statistics background necessary to execute the methodology in these projects. Furthermore, given that each data set and model has its own inherent bias, we believe it's important to externally validate these predictive models whenever possible. Lastly, I want to take a moment and thank everyone who has been involved with these projects here in the Stanford Outcomes Lab. Their names are listed here. And thank you to you, the listener, for your time. And thank you to the organizers for this event.